Good morning, everybody. I'm Andrew Goddard, President of the Royal College of Physicians, and it's an absolute pleasure to welcome the Secretary of State for Health and Social Care, Matt Hancock, this morning to give a speech. It's really great to see people back in the college, and I know that as well as the people in this room, we have hopefully many hundreds of people watching on the stream service through the RCP player. At the end, we'll be taking some questions. Those in the room will be using the VVox app, but those who are watching on the RCP player can ask questions through the player. But without further ado, I'd like to introduce Secretary of State for Health and Social Care, Matt Hancock.
Thank you very much indeed, and thank you very much for hosting this event and this speech. And I want to start by taking you back to the tail end of a long and hot London summer many years ago. One night, late at night, at a bakery in the city, a spark leapt out of an oven and ignited some nearby fuel. London's largely timber-framed buildings were bone dry at that time and tightly packed together in the narrow and unplanned medieval streets. The year, of course, was 1666, and we all know what happened next. When a system is hit with a big external shock, it can be utterly devastating. London lost a third of its buildings in the Great Fire, including its cathedral. 100,000 people were made homeless. And the cost of rebuilding the city has been calculated in today's money at £37 billion. But that same devastating shock can also force people to find new and better ways of doing things. The London Fire Brigade, the first insurance companies, building regulations that enforced access to running water, and, of course, Wren's domed cathedral, the most ambitious public works project in the history of the city. All of these have their origins in the nation's response to the Great Fire. And in that, there is a lesson for all of us. Because once again, we've been hit with a terrible shock. A small spark that quickly turned into a global crisis. Coronavirus has tested every single part of our infrastructure, giving us a new appreciation for what works and what doesn't. And once again, brilliant, ingenious people have risen to the occasion. Now, it's a long time since I've given a speech like this, and a long time since I've been in front of an audience. And these last few months, we've all been working together every waking hour to try to lead the nation through the coronavirus crisis. And I am fully aware of the pain and the suffering that this virus has brought to so many people. And we pay tribute to everyone that we have sadly lost. Throughout this difficult time, we have protected the NHS and in turn helped protect us. And that was thanks to the heroic efforts of many, many people. This was a great achievement in very difficult circumstances. But we all know that we haven't got everything right and that there will be lessons that we need to learn from this pandemic. This includes what we've learned both from our healthcare system and about it. And today I want to take a moment to step back from the vital work in the management of the COVID-19 pandemic. That work, of course, continues every day as we strive to keep the virus under control. We can see a second wave emerging in Europe, and we will do everything in our power to stop it reaching our shores. However, today I want to talk about what we've learned about the health and social care system in this country, how it worked during the crisis, how it should work best in future. So first, what have we learned? Coronavirus has been a moment of stark clarity, of exposure, like sheet lightning on a dark night. It has suddenly and dramatically revealed our healthcare landscape in a way in which we've never quite seen it before. We've discovered things about the system that we could not have learned in normal times. How it performed under conditions of severe, sustained and nationwide pressure. The choices that frontline professionals make if you give them greater freedom. What rules and structures are essential to the effective delivery of health and social care, and what are just a layer of bureaucratic barnacles that can be stripped away to streamline the vessel beneath. If you think about it, in terms of mobilizing the resources of the state, the pandemic has been as close as you can get to fighting a war without actually fighting a war. We achieved things that people never thought possible, like building Nightingale hospitals in 9 days, or doubling ICU capacity to treat the most sick, or treating half of patients in outpatients and primary care online. At the same time, our brilliant scientists drove forward the first robust clinical trial to find an effective treatment for coronavirus, and they are currently leading the world in the search for a vaccine. And coronavirus has catalyzed deep structural shifts in healthcare that were already underway. Telemedicine, data-driven decision-making, and working as a system, not as atomized institutions. And just like a war, it's forced us to improvise new ways of doing things, some of which will become permanent because they are better ways of doing things. So, for instance, before coronavirus, there were plenty of theories about how to transform health and social care. In fact, the last 30 years is littered with top-down reorganizations and big bang structural reforms. Quangos and quasi-markets and theories and pilots and reports and boards and commissions, but something important has changed. In the post-coronavirus world, we don't have to rely on theory because we now have hard evidence of how people choose to operate under crisis conditions when there is a novel and acute need to deliver. We must learn from how the NHS and social care worked during the peak, both about what we must change and critically, because so many things went right, we've got to bottle the best. And this, in a way, is how I see my job, my role as Secretary of State for Health and Social Care. Not to impose some preconceived utopia that might look good on a management consultant's slide deck but bears no relation to reality on the ground. My job is to make the system work for those who work in the system and work hard to free up, to make the system work better, to free up, to empower and harness the mission-driven capability of team healthcare. So what do I mean by this? For an illustration, come with me to Helsinki. In Finland, the town planners visit a park immediately after snowfall because the footprints reveal the paths that people naturally take. The next summer, they go out and they pave those paths. They don't sit in an office and decide where to put the path. They watch where people go naturally, and then they pave the way. We too must pave the paths that people want to travel, because our healthcare system isn't just complicated, it's complex. It's best led not by diktat, but by mission. And we are now at a critical moment in that mission. We're carefully restoring our healthcare system, and as we do so, we must not fall back into old bad habits. Instead, we need to take what we've learned and build back better, capturing a culture that's open to collaboration and change. And I just want to dwell on this collaboration point. We saw collaboration like we've never seen before, between different organizations, different professions, between different teams in different organizations. And we saw things change, and I mean really change. I've lost count of the times that someone has said to me since, what would have taken months took minutes. In the heat of the crisis, we saw a shared understanding that accepted truths or ways of doing things had to be challenged if they didn't help. That the needs of the patient mattered more than the silos between institutions, and crucially, that we value the contribution from everyone in the team. Now, throughout, I've been talking to people responsible for making the system work, from regulators to frontline staff, to leaders of trusts, to local directors of public health, and I ask what they think are the things we need to bottle. In organisations as diverse or as nice, the Royal Colleges, the BMA, people tend to come up with the same list. Collaboration, we work better when we work together. Speed, it doesn't have to take weeks and months to change anything, no matter how small. And innovation, that it's not about coming up with the idea, it's about having the backing and the permission to make the change. I couldn't agree more. So today I want to start a conversation about how we can put these values into action, how we can capture a culture that lets our carers care and scythes away at the red tape, attitudes, and ways of working that stand in the way. And to do this, I'd like to draw on 7 major cultural lessons that I think we've all learned over the past few months. The first is that we must value our people and trust them as professionals. Now, it's easy to say that we should value people, but there are some hard-edged changes that need to make it happen in reality in the NHS and social care. Too often, before the crisis, people were treated as numbers on a spreadsheet when they're actually the most important asset that we've got. And when I say people, I mean all our people. Care workers, porters, cleaners, clinicians and leaders. Everyone of every background in every part of our health and care system has a contribution to make. And everyone needs to be supported to do their best possible work. Now, some of you may have heard, I love the story of JFK visiting the NASA Space Center. He saw a janitor carrying a broom and asked him what he was doing. "Mr. President," the janitor said proudly, "I'm helping to put a man on the moon." Now this, to me, is what it means to be a mission-led organisation. And we know what support for staff looks like in practical terms. Because as well as that great outpouring of emotional support from the British public, the crisis brought real practical help for the front line. Good food, decent rest facilities, someone to talk to about the most difficult experiences that frontline colleagues faced. It shouldn't take a pandemic. All of this needs to become the norm for the NHS and social care. That we listen to our people and we look after them, not just in an emergency, in a response to a crisis, but all the time. And I'm determined to make it happen. We've also learned that people do their best work when they're trusted to get on with the job. Don't just take my word for it. Look at Admiral Nelson, one of the most inspirational leaders of all time. When the British Navy was heavily outnumbered at the Battle of Trafalgar, it was Nelson's approach to leadership, the Nelson touch, that proved to be decisive. He worked hard to build an agreed strategy that everyone knew and understood. And then he expected everyone to use their own initiative to put it into place. So amidst the fog of war, while his adversaries were hamstrung waiting for instructions from their admirals, transmitted by cumbersome flag signals, Nelson's fleet knew what they needed to do, and they were trusted to work out how to do it. Admiral Villeneuve, whose fleet was defeated by Nelson, said it best. He said, "To any other nation, the loss of Nelson would have been irreparable. But in the British fleet, every captain was a Nelson." And this is the mentality that we need. I want an NHS and care system that is full of leaders at all levels. This is the principle embedded in the people plan released today and that underpins everything that Priyana Issing is trying to do brilliantly in the NHS. Everyone at all levels thinking like a leader and being encouraged to use their initiative and take ownership of their decisions. And that means getting rid of what stands in their way. I think it is vital to understand what happened when we made emergency changes so staff could focus on the crisis. Take the GMC and the NMC, who set up registers for extra healthcare professionals and gave professionals the flexibility to postpone their revalidation, allowed students to continue their studies while at the same time contributing to frontline care, and most audaciously of all, gave clinicians from areas far removed from respiratory illness, for instance dermatology, gave them the confidence to work in unfamiliar COVID wards. Or look at the CQC's emergency support framework. The CQC adapted their traditional inspection-based model of regulation to the new reality, using data and feedback to identify problems in real time. And where there was a problem, working with them to have honest conversations and provide ongoing advice and support. Now, when we made all of these changes, the sky didn't fall in. On the contrary, the NHS was protected, patient safety was protected, and crucially, frontline staff felt empowered. But empowerment is not just about giving people the freedom to make decisions. It's also about requiring them to make those decisions. If you give people responsibility, they will act responsibly. So we cannot and we will not revert back to before. The GMC, the NMC, the Royal Colleges, the Academy of Medical Royal Colleges, the CQC, NHSE, we are all together on this mission. The regulators, our NHS and care colleagues excelled during the pandemic, showing their ingenuity, their resilience and their versatility when it mattered. And over the coming weeks, they'll be building on the action they've already taken to put this agenda into practice for the long term. Today, the NHS published the latest part of its people plan, and aligned to this vision of an empowered culture where leadership at all levels supports every single NHS employee to reach their potential. This is all about building that culture of trusting people to use their professional judgment to do the right thing, instead of appearing to assume that someone will do the wrong thing unless they have layers of management peering over their shoulder. Together, we'll build a system of distributed authority where decisions are made as close as possible to where the information is, with everyone working right at the top of their skill set and qualifications, where people feel empowered and encouraged to crack on with improvements instead of having good ideas blocked by bureaucratic inertia. And in a world where multi-morbidity is increasing, where we encourage and celebrate generalist skills as well as supporting those who want to specialise. Frankly, we employ some of the most compassionate, brilliant, intelligent, mission-driven people in the world in our health and social care system. Why stop them from doing their best? This has got to change. That brings me to my second lesson, supporting a culture of collaboration and change by busting bureaucracy. Now, we shouldn't beat ourselves up too much about this. The latest OECD data shows that we only spend 2p in the pound on administration in the NHS compared to, for example, 6p in France and 8p in the USA. But the crisis proved that there's more bureaucracy that our healthcare system can do better without. That barnacle-like encrustation of rules and regulations. And I can see people smiling, and I know that everybody's thinking of some particular frustrating, illogical rule. It's been disempowering to many of the brilliant, highly motivated frontline staff who just want to get on with caring for patients. Now first, a caveat. Healthcare is a risk-based business. Many of the rules exist for good reason. Of course they do. High-quality rules are the tram lines of high performance. We know that checklists save lives. We know that professional standards must be rigorous and exacting. Clear standards are necessary for a disparate system to function. In the crisis, we imposed some clear high-level rules, for instance, around infection control. And tech standards are vital for interoperability. Done best, high-level, mission-based standards support people to deliver within them. Done best, the centre sets clear tram lines and holds the front line transparently to account for delivery. Kennedy set NASA the goal of getting to the moon by the end of the 60s. He did not specify what alloys the rocket should have been made out of. We need a framework that encourages local initiative in service of the overall goal. Again, the pandemic forced us to decide which rules and processes were essential to the NHS mission and which were getting in the way of that mission. Sometimes it's just an encrustation of decisions that are made over time, like the regulations which required thousands of pages of information from doctors who want to move here from Australia, which have been removed. Other times, it's how the law is overinterpreted with layers of gold plating. Our information governance rules are a good example of the latter. Complex, confusing advice leads to over-cautious interpretation. For instance, without changing a jot of the law, early in the crisis, NHSX issued radically simplified new guidance to support new ways of working. This guidance, information governance guidance, was on one page and targeted at every single frontline professional, not just the information governance experts. For example, we made it clear that it's fine to use secure messaging services like WhatsApp to share information with colleagues or patients where the benefits outweigh the risks. And we made it easier to link the primary care records of millions to the latest data on coronavirus, helping us to do the world's largest analysis of coronavirus risk factors. This work would normally have taken years, but thanks to our new framework for processing data, it went from proposal to execution in just 42 days. I can't tell you how many people at all levels have begged me never to go back. And it worked because the emphasis was on enabling, on how people can safely share information rather than an emphasis on restricting. And now we'll work to simplify that guidance yet further and make it yet more empowering. Rest assured, this bureaucracy will not be coming back. In fact, in the future, I want us to go even further. That means lesson 3. Better tech means better healthcare. We want to double down on the huge advances we've made in technology within the NHS and social care. Because it's not really about technology, it's about people. It's the child with cystic fibrosis who can have his lung capacity measured at home with a spirometer and an app instead of having to go to hospital with all the risks that that entails. It's the elderly care home resident, socially shielding for months, able to meet her new grandchild on an iPad. It's the local GP, already time poor, not having to spend time donning and doffing PPE because she can do her care home check-in online. Now, I know that I've taken a bit of stick for making technology one of the central issues for the NHS. Before coronavirus, there was a view advanced by some people, would you believe it, which held that anyone over the age of 25 simply could not cope with anything other than a face-to-face appointment. That video consultations, a technology, by the way, that's been around for decades, was too modern and too newfangled for the NHS. Remember that? That apps had about as much relevance to present-day healthcare as nanobot surgery and a mission to Mars. When it came to social care, this attitude was even worse. Take away their fax machines, people told me, and care homes will collapse. Well, all I can say is thank God we didn't listen to the naysayers, and that NHS Digital, NHSX, and NHS teams right across the country worked so hard on digital transformation. Imagine if we hadn't put the investment into broadband infrastructure so that 99% of surgeries could offer remote consultations virtually overnight. Imagine if we hadn't digitized prescriptions so people could get repeat prescriptions online. Or imagine the massive pressure on NHS 111 at the peak of the pandemic if we hadn't developed it also as an online service. At a time when over 750,000 online assessments were carried out in just one day in mid-March. Now, of course, sometimes developing new technology is hard. And you have to have an attitude of iteration and of flexibility. But none of that makes it any less valuable. So to promote collaboration and change, we need more transparency, better use of data, more interoperability, and the enthusiastic adoption of technological innovation that can improve care. This crisis has shown that patients and clinicians alike, not just the young, want to use technology. Just look at how many families of all different generations kept their precious encounters going through parties on Skype and quizzes on Zoom. And when it comes to their healthcare, whether they're digital natives or digital converts, they don't want to sit around in a waiting room if that service can come to them at home. In the 4 weeks leading up to the 12th of April this year, 71% of routine GP consultations were delivered remotely, with about 26% face-to-face. It was the same, in the same period a year ago, this was reversed. 71% face-to-face and 25% remotely. Now, of course, there always has to be a system for people who can't log on. But we shouldn't patronize older people by saying they don't do tech. The feedback from this transformation has been hugely positive and especially valued by doctors in rural areas who say how it could save long travel times, both for doctors and patients. So from now on, all consultations should be teleconsultations unless there's a compelling clinical reason not to. Of course, if there's an emergency, the NHS will be ready and waiting to see you in person, just as it always has been. But if they are able to, patients should get in contact first, via the web or by calling in advance. That way, care is easier to manage and the NHS can deliver a much better service. Not only will it make life quicker and easier for patients, but free up clinicians to concentrate on what really matters. The fourth lesson is about open borders. This crisis has shown that we're at our best when we're looking outwards, drawing on ideas and expertise wherever they may be found. And that means the private sector too. And that takes me on to this fourth lesson. The NHS needs open borders. Better joint working between local authorities and the NHS locally to embrace the solutions that work. They say there are no atheists in a lifeboat. Well, there are no ideologues in a pandemic. Take testing, for example. If you'd asked most people who'd taken a swab test, whether they were part of Pillar 1 or Pillar 2, you'd have had some fairly blank looks. People don't care who's provided the test. They just want a test that's easily accessible, that works, and that they can have confidence in. And I want to thank the teams, public and private, who put themselves on the front line every day to swab people at risk. Restrict yourself to the false divide of public or private, and you're only fishing for solutions in half the pond. As part of our response to coronavirus, we were able to call up the logistical know-how of Amazon, the production lines of Burberry, the car parks of IKEA, and literally the boots on the ground from the British Army. The independent hospitals stepped forward and provided services to protect the NHS, and the NHS worked side by side with them, all as part of an incredible national effort. One diverse, talented team working towards a common goal. And we're all better off as a result. In the face of unprecedented challenges, our sense of enterprise and pragmatism is mission critical to the success of our health and care system. It's part of a spirit of collaboration and change that we must bottle for the future. And now that we've taken this huge step forward, we should never walk back. Lesson 5 is that the system works best when it works as a system. Collegiate, cooperative, collaborative. These are some of the phrases I heard. As opposed to a series of atomized, fortress-like, rather lonely institutions. The future of health and social care will be built by those striving to keep the population healthy, not just to fix the ones who are ill, just as spelt out in our NHS long-term plan and in our social care reforms. This can only be done by the delivery of healthcare based on the needs of the population, not on the design of the institution. To deliver this type of care, systems will become the foundation stone of the future of the NHS and social care. We've already seen local areas in England embracing system-wide working, with more streamlined planning, bringing together clinical commissioning groups, providers, and local authorities to plan services across an area. These plans will, of course, help reduce admin costs, but that's only half it. System working means better, less fragmented decision-making. This is how people work when they really need results. So we must work to break down the silos that exist between providers and trusts of all kinds. Primary care, community care, pharmacy, mental health, acute trusts. The barriers between these services are decades old, but they don't work now, not in a crisis, and not in an age where ever more patients have the kind of long-term complex conditions which mean they can't just be bandaged up and sent on their way. The strict barrier between primary and secondary care goes right back to Lloyd George's National Insurance Act of 1911. Now, I'm a great admirer of David Lloyd George, but what was right for 1911 is not right for the 2020s and beyond. The past few months have shown that there is another way. During coronavirus, when many secondary care appointments were cancelled for those with chronic, complex conditions, primary care clinicians were able to support them, including using digital technology, to take advice from consultants where needed. So the best possible care could still be delivered in the community. Pharmacies provided open access support and care that's deeply embedded in the communities they serve. Pharmacies showed just how much more they can do. And this is the spirit that I want us to channel as we move out of this pandemic. Collaboration doesn't just mean inside the NHS either. The NHS must be connected to the places that they serve, coterminous with local authorities, where the crisis has shown that councils and the NHS can work wonders when they work together. Look at what was achieved with rough sleepers by working across the system, from housing to the NHS to public health to protect the most vulnerable. And then look at the acute response places. Take Thanet, a dedicated team of GPs, nurses, paramedics, AHPs and geriatricians that provide Thanet's 61 care homes with assessments and advice on all aspects of old age care. Now, during the pandemic, that model came into its own with 7-day support, so care homes and district nurses always had someone they could call if they couldn't get through to the local GP. Integration is not a silver bullet for all problems in healthcare, not by any means. But what is clear is that once you think about delivery of health and care as a system in a place, it changes the conversation. So money spent on a care package rather than in a hospital looks less like a loss to the hospital, for example, and more like a better outcome for all. There's a stronger imperative to treat people in the right settings, and data flows more easily. So together, we will build our future health and care system with the system by default. And this will include a financial and inspection approach that encourages and rewards collaboration. And as we do this, we need to look beyond healthcare and everything that makes us healthier and happier, recognizing that access to a gym or a park can have just as great an impact on our well-being as a GP surgery or a hospital. And we must move away from thinking about spending as an NHS pound or a council pound, but a Darlington pound or a Dudley pound. And we need local authorities in the NHS to plan and budget together, to work together, and to be accountable together to local people. And this brings me on to lesson number 6. Accountability matters. We also need this collaboration at a national level too. All of our national organisations have done exceptional, life-saving work during this crisis. The NHS has withstood the worst global pandemic in a generation. PHE rolled out a diagnostic test faster than ever before in recent history. And we saw the strength of the union coming to the fore, with a UK-wide approach helping us expand testing capacity, procure PPE for every corner of the UK, and of course search for a vaccine that can help us return to normal life. Just as we need a more joined up, collegiate working on the ground, so too we need the same at the centre. We're making progress on this already, with NHS England and NHS Improvement now operating as a single organisation. But our national healthcare institutions are too siloed, in many cases by law under the 2012 Act. Huge amounts of energy are wasted managing the legally imposed silos. That's why the NHS itself has proposed adjustments to join up services both nationally and locally. Fortunately, there are many practical steps that we can take now. Take just one example. We have many bodies DHSC, NHSD, NHS-E&I, PHE and the CQC all making separate information requests from providers, often for the same information. It is a huge burden, and instead we should ask for information once and use that across the system. This spirit of collaboration is so important, and nowhere is it more important than in the relationship between health and social care. We've heard about GPs going the extra mile for care homes and telemedicine enabling care in the peak of the pandemic. The NHS has also given every care home a dedicated clinical lead, and hospital trusts have provided thousands of infection control training sessions. One of the silver linings of this incredibly dark period has been the widespread appreciation for the care sector and the brilliant work that our carers do. Now it's time to set clear ambitions for the future of social care in this country and fix an issue that has been ducked for far too long. We should aspire for everyone to get the care they need at whatever stage of life they need it, given in the place that best meets people's needs by carers who are properly recognised and rewarded. We already know that we need a fairer system for paying for care that protects people from the exorbitant costs that require them to sell their home. And that we need to get more money overall into social care and fix the funding shortfall. Achieving this will involve bold reforms, not just about funding, but also effective structures for oversight and accountability. We'll be saying more about this over the coming months, but this is a top priority for me. So we can create an enduring model of care focused on early intervention, prevention, and technology, and keep people living independently for as long as is possible, supported by care that you or I will be happy about for our own daughter, father, or grandparent. And now my seventh and final lesson for today. Our NHS is a place where miracles are an everyday occurrence, but they cannot, must not, shoulder the whole burden of keeping the nation well. The nation's health is so much bigger than just the NHS. The best evidence suggests that only about a quarter of what leads to a longer, healthier life is the result of what happens in a healthcare system. Prevention matters, as the pandemic has vividly shown. That sheet lightning revealed that your chances of dying with coronavirus are tragically markedly higher in a more deprived area, much higher for the obese, and much higher for people from an ethnic minority background. This should be a wake-up call for us all. As a nation, we went into this crisis in worse health than some of our peers. Japan and South Korea, for instance, have the lowest rates of obesity in the OECD, and this left us more vulnerable to the disease. This is not the only factor that explains our relatively high mortality rates during the pandemic, far from it. But nor is it a factor that any responsible government could just ignore. The lightning strike of the pandemic exposed stark inequalities in the health of our nation, between ethnic groups, between city and country, between occupations. The disproportionate impact of the virus upon black and minority ethnic people, including in the NHS and care workforce, has been particularly troubling. People are understandably angry about these disparities, and I feel a deep responsibility to get this right. Because the quest for equality isn't just about jobs and housing. The Prime Minister's mission is to level up, and there is no more important levelling up than levelling up your health. In this country, there is a complex interaction between ethnicity, economic opportunity, and healthy life expectancy that we need to urgently understand and unravel. And that means asking difficult questions about the way in which our society is configured, about who gets to work from home and who does not, about how much easier it is to have a healthy life if you don't have to worry about the next month's rent or next week's food shop. There's a famous passage in The Road to Wigan Pier where Orwell is talking about the diets of unemployed mine workers, which in 1937 consisted of white bread, corned beef, and sugary tea. When you're unemployed, Orwell said, and I quote, which is to say, when you are underfed, harassed, bored, and miserable, you don't want to eat dull, wholesome food. You want something a little bit tasty. There is always something cheaply present to tempt you. And the structure of our economy and the makeup of our society have both changed hugely since the 1930s, but that insight of Orwell's is borne out by modern epidemiology. It is harder to stay healthy if you are poor. So as much as levelling up on economic opportunity, we need to level up the nation's health and care provision too. And this isn't simply an aspiration, it is a moral imperative if we're to uphold the values of equality and fairness upon which the NHS was founded. But there's no easy answers to any of this. The causes of ill health are complex and multifaceted, and our response must be too. We must understand who is most at risk of COVID and why, and I'm working with Kemi Badenoch on urgent cross-government work on this. Longer term, we must be more proactive on public health. Earlier this week, we launched our new obesity strategy, which is full of measures to help people make healthier choices, like mandating clearer calorie information in restaurants and takeaways, banning the advertising of high-fat, sugar and salt products before 9 p.m. on TV and online. But this is the beginning and not the end of our work. And one of my main priorities is making sure people stay out of hospital, as well as providing the best possible care when they come in. And the NHS has a vital part to play in that, supporting people to make healthy choices and using those teachable moments to help people to make the change, with employers and town hall planners and the food and drink industry all playing their full part too. And we must keep striving to add life to years as well as years to life, not giving in to the defeatism that says you can't have a healthy old age. So what do we need to do? These for me are the 7 biggest lessons of the crisis with respect to the health service. But this is only the start of the conversation, and I want to hear what you think too. From frontline staff to regulators, from chief execs to caterers, across health and social care. I want to discuss what works and what matters to you, so as we implement our long-term plan, and what we need to change. What we need to change to get there. Inside the department, we've been looking at this and we've already mapped out over 50 different reforms that we've introduced due to coronavirus that we want to keep and drive forward. Where the question is not what to roll back, but how to go forward, how we can build back better. And there are a few themes that I think are especially important. First, we need to push power out of the centre to closer to where care is delivered. Second, we need to tackle unnecessary bureaucracy. So I'll be setting up our health and care system a bureaucracy challenge. Challenging every new proposed regulation or process and asking if it makes sense given the realities of modern integrated healthcare. This means inviting everyone who has to work under this bureaucracy, from the most eminent Royal College president to the most junior healthcare assistant, to tell us what they think should be scrapped or improved. Today we've launched an open call for evidence on this to invite views from the health and social care colleagues on how we can bust bureaucracy. This is unapologetically based on the red tape challenge that we issued to business after the global financial crisis and which helped spur a British jobs miracle. We don't need a pilot to know how necessary this is in healthcare. We've just seen how empowering it can be, and we must go further. Third, we need to drive forward the integration of health and social care by pooling budgets and giving NHS responsibility to support people out of hospital. We radically reduce the number of people getting care in hospital when they should have been at home. But there is so much more to do. All parts of the system need to pick up this agenda and drive it forward with what Martin Luther King called the fierce urgency of now. And there's one very urgent reason why we can't go back, which is winter. Though I deliver this on a hot summer's day, we know for sure that winter is coming. Unusually cold weather or a more virulent strain of flu would put real stress on the system. There's still a lot we don't know about COVID-19, from the long-term health impacts on those who've recovered to how it interacts with the cold. And although we work in hope that a vaccine will appear, we may have to live with COVID for some time to come. A health service that's collaborative and open to change will be much better placed to withstand whatever headwinds will come. So I hope that you'll join me on this mission. At a time when the world around us is changing faster than ever before in human history, we mustn't simply keep pace with the change, but once more show the world what can be done. We need a health and care service that is built on collaboration, not competition, on trust in professionals, not box-ticking bureaucracy, and protects the most vulnerable and helps people live longer, healthier lives. And just as modern London rose from the ashes of the Great Fire, we protected the NHS in the peak of this epidemic. And out of its ravages, let us build a health and social care system for the future. Thank you very much indeed.
Thank you, Matt. So I know that we're a bit pushed for time, so we've probably got about 10 minutes for questions. There's a huge amount there that I think many of us in the room, and I presume watching, would have never expected to hear from a Conservative Secretary of State for Health Service, and some of it's absolutely fantastic. The focus on prevention, focus on collaboration, talking about people, and understanding that the workforce is what keeps it all going. So we've had lots of questions, so it's going to be hard to pick them, but the first one I might start off with is, what are the thoughts of central government to support and attract and retain people in the sector in the medium term?
Yes.
The comment there is they felt this has got more difficult during COVID, despite rising unemployment, due to negative press and fear of what's been happening. I mean, my own reflection of that is I understood that applications for nursing posts and things
yes.
are at an all-time high. But how are we going to retain the workforce that we've got?
Yes, well, I'm not going to be Panglossian about this because it's true that the applications have absolutely skyrocketed, and that's great news, and we put a lot of work and effort into that. But the retention of those who work both in health and social care is clearly critical. The direction that we're trying to drive through is to make the NHS and social care a great place to work. And it's easy to say that and really hard to do. But what I put at the core of it is listening. Listening hard to exactly what it is that makes it easier to do the job you love. Because if I can characterize this, and this is inevitably a caricature, people love the fact that working in the NHS and working in social care is a mission-driven occupation. But often, it seems that the system makes it harder and a less enjoyable place than it should be, given the mission. And you're smiling. I know that you're thinking of how the system makes you feel. And that's partly because we've taken a policy approach in the past that has been too top-down. And instead, we need to actively listen to find out what are the things that will make it easier for you to do your job, the job that that is a vocation that you've gone in to health or care to deliver, and then act on what we hear. And Brianna Essing is here. She's an absolutely inspirational leader in the NHS, the NHS's first Chief People Officer. And the people plan we've set out today, we have purposefully separated from the important work on how many people we need. And of course we need more, and we're hiring fast. Over the last year, we've had more than 13,000 more nurses in the NHS. It's excellent. But we've purposefully set out separately the culture and leadership changes we want to see, and really simple things like easy access to high quality food, so that when you're on a busy shift, you can get good, nutritious food easily, instead of that being a complete pain in the neck. Now, that would seem blazingly obvious. And when you ask people what they want, they put that very high on the list. And during the pandemic, sort of bottom up, it just started to happen, and we've got to drive that forward. So respecting the staff at all levels and supporting them to be the best they possibly can be is a critical insight that all good employers hold dear and act on. And that's what is at the heart of the people plan. And I sincerely hope that will help with retention. And where this question normally then goes is, but what about pay? And what about pay? And of course pay is important as well, and we've got the 3-year Agenda for Change deal. But the problem is that because the high-level debate so quickly in the past has run straight into the question of pay, we don't spend enough time stopping and asking all the other things that we should just be getting on with. I've been working with Jeeves, the former head of the BMA's Junior Doctor Committee, and he did a brilliant paper on, I said, you can't do pay, do everything else. All the non-contractual stuff, things in the contract that get in the way. He wrote a brilliant paper about, and there were about a dozen things which really matter to people to make people's lives easier, and we're taking that forward. So the people plan is emphatically about retention because it's about making the NHS a great place to work, and the same, it's harder in social care because we are not the direct employers, and local authorities are the formal route of accountability and indeed contracting. But we try to look at this across health and social care as much as is possible, despite the fact that in different areas there's a different model of employment, if you like. In the same way that pharmacies are very much part of the NHS, but they have a different model of employment. But nevertheless, we take an overall view of supporting our people to do the best job they possibly can. And this people plan is not just a one-off. We had an interim last year. We had a publication this morning. We've got another one coming in the autumn, which will be more about the numbers alongside the spending review. And then there'll be more, because our people planning is a process, not a document.
Yeah, and so I think we welcome the people plan and its various iterations as it develops. And I think that a huge amount of work has gone into that, and I'm very grateful to all the people that have done that. As sort of having been asked about it and sort of inputting into it, it's been really good to hear about the focus on people rather than
clues in the name.
Bureaucracy. So it is good. So you talked about the comprehensive spending review, and that's going to be critical when it comes to thinking about growing the workforce, but also about the estate. And so there's a question here, because you started off about rebuilding the Fire of London, and it's a question from one of my compatriots, Adrian James, at the Royal College of Psychiatry. Mental health services need a significant investment regarding IT, buildings and workforce. How can we influence the spending review to get much needed investment?
Yes, so I agree with the premise of this, and it's something that we're working on. We have seen a very significant increase in investment in the last 2 years or so, and the Prime Minister absolutely has this at the front of his mind, and I'm working very closely with him on it across the board, including in mental health services. And for instance, we had the investment that the Prime Minister announced a couple of weeks ago, getting rid of mental health dormitories, significant investment there, but I appreciate that there's more to do, and that IT investment, I can't have a whole section of my reflections on IT without reinforcing the need for, that needs money as well as a culture of accepting flexibility.
Brilliant. Okay, so one last question I think we've got time for. So we talked about sort of remote consulting. So we've experienced the benefits of some of the risks and challenges of remote consulting. More research is required to understand these. What do you think the role of patient choice, shared decision-making is when it comes to the mode of consulting? So how do you think the patient gets involved in taking the digital agenda?
Yes, look, it has to be a shared decision. Of course it does. Right? There are some people who will never go online. And and health and social care, these are universal services that we choose as a society rightly to provide to everybody, and therefore, of course, there needs to be a non-online version. But we mustn't let that get in the way of the fact that the vast majority of people can go online, and a very large swathe of society prefers to do these things online. And that actually leads to a better service to those who need face-to-face treatment to the extent that it frees up time. So why technology had a specific section in this speech is not just because it's an area that I feel strongly about because it can improve care. It's about people. It's also that the absolute radical improvement in the take-up of technology, where thank goodness, thanks to great work over years of NHS Digital, they'd put in place the sort of infrastructure underpinnings. Of course, it can be better. I accept that, but they've put in place that. And then with NHS-X, which is the strategic body, for instance, changing the IG rules, we could really accelerate. And so when the culture change came, things moved very fast. And the key is that we don't go back. We do provide face-to-face where needed, whether that's because you need a physical interaction to give the healthcare, obviously, or because somebody doesn't want to. But we also make available Zoom medicine.
Brilliant. Yeah, I mean, so I can remember when we first sort of talked about 30% of outpatient consultants being done virtually, and then that came into the long-term plan, and everybody said, "Don't be so stupid. That's never going to happen." And
yes.
Overnight,
we're at 50. Yeah. And really, what I'd say is this: why this is related to the pandemic is that in the pandemic, people stopped asking, "How did I do it yesterday?" They started asking, "How can I best do this?" Full stop. And that's the question that we need to be asking. And that is what will help us to get through this winter. That is what will help us build the best NHS and build best in social care. And I want to capture that culture change that people who, those who might have said, "Oh no, it's not going to happen," or "It's never going to happen," or "People will hate it." Well, we've tried a load of these things, and do you know what? The vast majority of changes we made, people liked. Both patients and clinicians. So it's this is an ode to the evangelists, and it's a no to the naysayers. And I want to empower people everywhere in the NHS. If you're a reporter thinking about how you can use technology to optimise your routes around the hospital, or if you're a ward matron thinking about how you run your ward, get on and make the improvements. And if you're part of the management structure, empower people to make those improvements and let them get on with it, and the system will back you. And I appreciate we've got to change some of the formal rules in order to formalise that the system will back you. But that's what you should do. You shouldn't wait to be told what change to make. Everybody, all 1.3 million of us in the NHS and all those in social care, look at what you can do to improve the area that you work in and get on and do it. And the system has to be designed to back that improvement and to support and empower you to make it happen.
Brilliant. What a great note to finish on. So, Matt Hancock, Secretary of State, thank you very much for your speech today.
Thank you very much indeed.